My 10 tips on successful DMEK surgery. DMEK stands for descent membrane endothelial keratoplasty, in which we replace the diseased endothelium and descent membrane by another healthy endothelium and descent membrane. So thanks for these tiny fragile DMEK tissues that allowed us to make a revolution in management of endothelial decompensation. The advantages of DMEK over penetrating keratoplasty are so many. It has a very low rejection rate, 25 times less than penetrating keratoplasty. It has a very fast visual recovery. DMEK needs days versus penetrating keratoplasty, which needs months or even years. The minimal change in refractive error, the normal unchanged ocular surface, no suture related complications, no huge amount of post-operative astigmatism, intact globe which can resist trauma, no intraocular complications. We work in a closed eye surgery. And finally, the triple phaco is much safer and controlled if compared with the triple extracapsular penetrating keratoplasty. As you see from these two videos, the triple phaco is controlled working in a closed eye conditions, but you are working in triple open sky extracapsular PKB in a very risky and uncontrolled way. The MEC technique has too many steps: donor tissue preparation, the MEC graft loading, recipient preparation, injection of the MEC roll in the anterior chamber, and after injecting the MEC roll in the anterior chamber, we start make the MEC graft orientation, the MEC graft unscrolling and centration, and finally gas or air tamponade with SF6 20%. Throughout these steps, we have a lot of tips. So in this talk, I will try to show my 10 tips for successful DMEK surgery. Tip number 1, DMEK case selection. DMEK is best with a bicameral eye with a normal anterior chamber volume and intact lens iris diaphragm. So in your early cases in your learning curve, try to do pseudophakic bullous keratopathy, DMEK alone, not combined with cataract. And if you can, do inferior iridectomy before the operation by YAG laser. It will be much easier for you. During these early cases, avoid 10 things. Avoid gross iris synechia, avoid vitreous in the anterior chamber, avoid distorted pupils, avoid glaucoma tubes, avoid large iris defects, avoid high myopia because the unfolding of the DMEK roll in a deep anterior chamber is very difficult. For the same reason, avoid aphakia and avoid previous vitrectomy, and avoid unstable intraocular lens, and finally avoid hazy view. Tip number 2, DMEK tissue preparation. It is a critical step. Donor tissue is prone to tears and endothelial cell loss. As you see, these delicate DMEK rolls, each roll has about 150,000 fragile endothelial cells. So you have to be very careful during DMEK tissue preparation. For this reason, you have to start your learning curve in a wet lab, and don't waste your dull cases, and try to learn how to make tissue preparation for the MEC because you are working without any stress and you are using your DALC case for training for the MEC. Donor tissue criteria is very important. It shows age above 60 years because, as you see, older donor has a wide roll and younger donor has a very tight roll. So if you have a donor age above 60, you will be having a very easy unfolding in the anterior chamber. The lens should be phakic. If you use a pseudophakic donor, you will be having the scars of previous cataract surgery, which may be a source of tears during preparation. The endothelial cell count should be at least 2400 cells per square millimeter, and I prefer that the donor to be non-diabetic. Size the DMEK graft before operation, because the DMEK graft is not a standard size. It depends upon the patient eye size. So project a slit lamp beam over the cornea and find the length of this beam according to adjustment to leave about 1 millimeter from the limbs. This will give you the future DMEK graft diameter before surgery. Use vacuum punch for proper donor holding, and always work under high magnification and under BSS, because the dry desmet membrane is very fragile and it is liable to tear. So always work under BSS to avoid tearing. Some general rules during preparation: start dissection from periphery to center, leave safety margin from the 8 millimeter mark, make superficial scratches in desmet membrane, don't include Dua's layer in these scratches. Always keep an eye on these points during stripping, because these points are the source of peripheral tears. Be aware of desmet membrane tears and manage immediately. This example for a desmet membrane tear: you turn the sharp edge tear into a rounded tear. This is another example. So this radial tear, you have to turn it immediately into a round edge tear to avoid extension of this tear in the DMEK graft area. So be aware of these tears and manage immediately by turning these sharp edge tears into rounded tears. Be aware of the concept of corneal splitting. You can use one donor for two operations. You can use the first graft is epithelium and stroma, could be used for adult patient, and the second graft is desmet membrane and endothelium, which can be used for a DMEK patient. You have to be familiar with the different types of DMEK tissue shapes. This is a wide roll, and this is a double scroll, and this is triangular DMEK roll, and this the unfolded DMEK roll, and this is the tight DMEK roll. This usually due to young donor age. You have to be aware that the tight DMEK roll has difficult unfolding if compared with the wide DMEK roll, and you have to know also that the tight DMEK roll has difficult unfolding if compared to the easy unfolding of the double DMEK scroll. Tip number 3, DMEK graft loading. Very careful sucking of DMEK roll inside the glass pipette. Try to use the no touch technique. If you are using the intraocular lens cartilage, submerge the intraocular lens cartilage in BSS and avoid air during loading of the DMEK graft in the intraocular lens cartilage, as you see. If you are using glass pipette, we use the wide part of this glass pipette to suck the DMEK graft under BSS, and then we will use the narrow part for injection in the anterior chamber. Tip number 4, improve visualization. Epithelial peeling is very important to improve visualization, as you see, and you can use Trepan blue staining for 2 minutes, which will give a very dark blue color, which improve visualization during unfolding technique. So use a high quality Trepan blue stain in these situations. I want to notice that the S stamp is not for visualization, it is for orientation. Tip number 5, the wound construction and marking is very important. We do mark for the dysmatorexis, and this is the DMEK graft. As you notice, we leave a thin rim of bare stroma. The DMEK graft size should be smaller than the dysmatorexis size. Avoid overriding of the DMEK graft over host desmet membrane to avoid graft detachment after the operation. We do the main wound, and I usually do 3 side port incisions. All these incisions, the internal lip of these wounds should be peripheral to the dysmatorexis. This is how to do the wound. We do marking first for dysmatorexis, and then we do 3 side port incisions at 3, 9, and 1 o'clock, and then we do the main wound. If you are using glass pipette, you can use a wound size from 2.4 to 2.75 millimeter. Tip number 6, patient preparation, and the most important step is dysmatorexis. We should ensure complete removal of desmet membrane. We should ensure perfect sizing of dysmatorexis in relation to the DMEK graft size. There should be no remaining desmet membrane tags which prevent proper DMEK graft attachment. The stroma should be respected without any injury during stripping, especially in the center, to ensure quality of vision. So you can do dysmatorexis under air. It has an excellent visualization, but the anterior chamber is not stable as you see. Or you can do dysmatorexis under cohesive viscoelastic. The anterior chamber will be very stable, but the visualization is not as clear as if you are using air. If you are using viscoelastic, you should use cohesive viscoelastic, and you are not allowed to use dispersive viscoelastic to avoid sticking to the stroma and preventing DMEK graft attachment. As I have mentioned, ensure complete stripping of desmet membrane. Don't leave any tags behind you. Be ready with microforceps to catch and remove any tags away from the wound. Tip number 7, inferior iridectomy to prevent pupillary block. Do it from the undersurface of the iris to avoid cutting through the zonules and vitreous. If you are using the vitreous cutter, you can put the cutting rate on 100 or 150 cuts, and the vacuum should be between 250 to 300 millimeter mercury. So you go under from the undersurface of the iris and do a small inferior iridectomy, as I have mentioned, to prevent pupillary block. But be careful, sometimes you may face a dangerous bleeding. Be patient, make perfect hemostasis, and then continue your operation, because blood and fibrin are enemies to the DMEK roll unfolding, so you have to continue your operation after complete removal of the blood and fibrin from the anterior chamber. Then after iridectomy, you do some confirmatory steps. You do thorough washing of the cohesive viscoelastic to prevent any sticking of the graft to the hilon or the viscoelastic material. You have to make a thorough washing, and then you have to inject air in the anterior chamber for more checking of the dysmatorexis, and if you have any tags you can manage at this time. And finally you suck this air and replace by saline, and you are ready now for the second step of injecting the DMEK roll inside the anterior chamber. Tip number 8, injection of the DMEK graft in the anterior chamber. It should be very careful. It should be slow, controlled injection of the DMEK roll. Try to keep the DMEK graft in the proper orientation if possible. Be careful of pressure gradient in the anterior chamber to avoid DMEK graft expulsion out. If you are using the intraocular lens cartilage, the anterior chamber maintainer is essential because there is little amount of fluid in the cartilage, and you have to remove the anterior chamber maintainer before you are getting out by your intraocular lens cartilage. Otherwise, the DMEK graft would be expelled after you go out. If you are using glass pipette, there is no need for anterior chamber maintainer because the glass pipette has a lot of fluid that can open the anterior chamber for you. Again, before going out of the anterior chamber, be sure that the tension is soft. During your learning curve, you may find some mishaps as you see in these examples. So, be aware of pressure gradient in the anterior chamber. So don't be upset and be ready and prepared to face such mishaps. Avoid bullet-like injection of the DMEK graft in the anterior chamber. Look for these two videos. The DMEK graft is injected in the anterior chamber like a bullet. This, of course, is not wanted because it may make a lot of damage to the anterior cells. To avoid this, you have to use a smooth syringe that allowed you to make a very controlled and slow injection of the DMEK roll inside the anterior chamber. Tip number 9, avoid upside down graft. Upside down graft equals primary graft failure in 100% of cases. So, as you know, to have to deal with these tiny DMEK rolls and to have this beautiful outcome, you should have three things. You should have a proper graft orientation. You should make gentle graft manipulation for unfolding of the DMEK roll. And finally, you have to have a proper graft adhesion or tamponade using air or gas. The natural behavior of any DMEK roll, it has the endothelium outside and descemet membrane inside. So this is the proper orientation of the DMEK roll inside the anterior chamber, the endothelium facing toward the iris, and the tissue scrolling up toward the stroma. So after you inject air, you will be having the DMEK graft in the proper orientation. But if you inject the DMEK roll in the other orientation, as in this example, you will be having an upside down graft and failure of your operation. So how to avoid upside down graft? The most common signs to avoid this situation: Motsori sign, intraoperative anterior segment OCT, and the SF orientation marks. The Motsori sign is a very simple sign in which we put the cannula above the DMEK graft and displace it sideways. If you find the cannula disappears under the fold, this means that the DMEK graft in the proper orientation, and we call it Motsori sign positive. This example of Motsori sign positive, you see, you put the spatula over the graft and then you sideways, you find that the spatula disappeared under the DMEK roll, so this means that it is a positive Motsori sign and you have correct orientation. Another example, we want to know whether this fold is facing toward me or toward iris. So put your spatula above the DMEK graft and watch You see, it disappeared under the fold, so this is a sure sign that it is a correct orientation. You can use air instead of a spatula. If you inject a small bubble of air in your DMEK roll and you use this bubble as if it is a spatula, you will find here that the DMEK roll, DMEK fold is coming over the air. So this is an indirect evidence that this is a positive Mitsuri sign. You see, the DMEK roll is above the air. So this, I call this positive Mitsuri sign using a small air bubble. If you are using anterior segment OCT intraoperatively, you can watch the unfolding as you see in this case, inverted graft, and then after correction, it is now in the proper orientation. The S or F stromal stamp. Why S or F? Because S, if flipped, it will be 2, not S, and if flipped, it will be 7, not F. So at the end of the operation, you should have this S mark, or you should have this F mark clear, as you can see. This example of S mark. This is how we do the S stromal stamp after making a stromal window, and how to do the F stromal stamp. You see, this is 2, not S. So this is an inverted graft. You have to flip the graft over, and you have to be careful in flipping, and then you will find now that the letter now is S. Another example, during unfolding, you will notice that it is 2 and not S, so you have to flip the graft over by injecting fluid in the direction of iris, and check again whether you can see the S mark or no. I just want to warn you that easy unfolding, as you see in this case, is not a guarantee for correct orientation. So this is a very easily unfolded graft, but you see it is 2, not S. So easy unfolding is not a guarantee for correct orientation. How to flip over an inverted graft? You inject direct short burst of BSS along the iris plane, as you see in this animation. It will help flip over an inverted graft. But don't aim directly at the graft, because this will push the graft to the angle and it will not flip it. Tip number 10, DMEK roll unfolding. To have a proper DMEK unfolding, you have some criteria for success. First of all, the visibility should be good by making peeling of the epithelium and using Trypan blue staining for 2 minutes. The anterior chamber should have a normal depth and anatomy, and you should have a proper graft size. And you should choose a donor age above 60 years to avoid this tight DMEK roll. And finally, you have to be patient during the unfolding process. All of the techniques rely on external forces or bubbles to manipulate the tissue into the correct position and conformation. There are some general rules during unfolding. The anterior chamber should be shallow but not flat. Use short jets of fluid and tapping on the corneal surface. It is best to maintain gross centration of the graft while unfolding it. In addition to centration, orientation is of utmost importance, as I have mentioned. Positioning the DMEK graft. You can't push a DMEK graft where you want it to go. You have to lead it. So use physics. This requires thinking about the physics of fluid and pressure as you work with this delicate tissue. DMEK graft unfolding techniques. This is the most difficult step because the DMEK tissue is very delicate with vulnerable endothelial cells. You should unfold the DMEK roll with gentle, indirect manipulations without damaging the endothelium. So the first technique is tapping technique, just simple tapping in the long axis of the DMEK roll will help open the DMEK roll. As you see from this example, you use the, the, the wave of fluid to open your DMEK roll. The second technique is the Dressmer technique. Pinch one edge from outside and unfold the other edge by tapping, and of course shallowing will be very helpful to have complete unfolding. The bubble in the roll technique: inject a small bubble in the roll and use this small bubble as a third hand in the anterior chamber, and with gentle tapping in different direction you will be able to unfold the DMEK graft. Sometimes repeated fluid injection may be helpful to open a tight DMEK roll. And finally, you may use the spatula for opening a DMEK roll, or you may use it sometimes in centration of the DMEK roll, as you see from this last example. So change your tactics along the way. Use all your techniques you got with whatever situation at hand. For proper graft adhesion after unfolding, we either use air, short acting, or we use SF6 20%, which is long acting and gives more time for tamponade. How to prepare SF6 20%? Suck 1 cc of SF gas, mix with 4 cc air, so we will be having a 20% SF6 gas, which is considered as non-expansile concentration. For proper air tamponade, I usually use 2 syringes, 1 cc insulin syringe and 5 cc insulin syringe. So the basics for proper graft adhesion: avoid displacement during air injection, and you have to use a good quality syringes. So after complete unfolding of the DMEK roll, you go by 1 cc syringe in the center of the DMEK graft and inject a small bubble to fix the graft and to avoid its displacement. And then you go by 5 cc syringe to make almost complete air fill, either using air or gas. I advise you to check the bubble size at the slit lamp after 1 hour of the operation. This is 60 to 70% gas fill. For myself, I prefer to have at least 85 to 90% gas bubble. So spend a few minutes at the slit lamp after the operation to judge your bubble size before letting the patient going home. Finally, as you see, despite all these tips and tricks, the DMEK still has hundreds of tips. It is a very delicate operation and needs attention to every minute details. The last question is why? Why I am doing this delicate operation or this difficult operation with tough learning curve? Why? The answer has two folds. The first part of the answer is because the alternative, which is the penetrating keratoplasty, has a lot of complications: expulsive hemorrhage, iris prolapse, wound leak, epithelial defects, disrupted ocular surface, dry eye, stitch abscess, glaucoma, astigmatism, graft failure, graft rejection, weak globe, triple PKB, and open sky extracapsular is a very difficult operation. And finally, if you reach this beautiful outcome after penetrating keratoplasty, you have to wait for a too long time. The second point is why we do this tough operation is because the marvelous outcome and the very fast recovery of the DMEK. So watch these cases, this triple phaco DMEK, and see how much the cornea is beautiful after few days only. Again, the cornea is compact very early, the air bubble is still there. So another two examples of the very fast recovery, no sutures, sutureless operation. Again, another example, watch carefully the very early recovery, the eye looks as if untouched, the cornea is compact, the air is still there. These are a lot of examples for the beauty of the DMEK. You see how much the cornea is compact and clear and the fast recovery, and still you have air in the anterior chamber. So finally you have to choose between doing the easy penetrating keratoplasty, which with its a lot of complication, or you have or to choose between doing the challenging DMEK with its marvelous outcome and very fast recovery. Thank you very much for your kind attention. I hope that you have enjoyed this video. Thank you.